All right, so psychiatric disorders of childhood and adolescence. Um, we're going to talk about multiple issues here, and we'll start with the objectives. At the end of this unit, you'll be able to tell the difference between oppositional defiant disorder and conduct disorder, risk factors for suicide in adolescents, and furthermore, how to ask them the questions. Autism spectrum disorder without language or cognitive component. What was it known as before the new edition of the DSM-5 came out? The three main subtypes of ADHD and what behaviors you observe with each subtype. What we need to teach parents when their child is on a psychostimulant medication for ADHD. How is that different when they have a medication like Strattera? Consequences of teen pregnancy, medical complications of eating disorders, the physical symptoms that you can observe from anorexia nervosa, and also the physical symptoms from bulimia, how those look different. And then we're going to talk at the end the effect of divorce on children. So there were two main studies on divorce that were very large studies that we're going to talk about in detail. All right, so childhood disorders, 1 in 5 children and adolescents at some point in their life have qualified for a major mental illness. This doesn't mean they have it chronically, that it's an ongoing issue, but at some point, children have had issues such as pretty serious depression, anxiety, school avoidance, um, sleep problems, bedwetting, other common childhood issues, getting bullied. All of those are, although bullying is not a formal psychiatric diagnosis, but it does lead to other issues. So anyway, most kids don't get treatment for this, and they just kind of develop out of it. And just comparing that to the kind of physical things that go on for kids, it's 2 to 3 times more likely that they'll have one of these psychiatric problems than any of the big ones that we see, the medical issues that we see in childhood, which is like asthma, childhood onset diabetes or bronchitis. So risk factors, boys tend to have more problems than girls. Substance issues, generally that happens in adolescence. If they have any kind of genetic predisposition, if the parents had any issues, we know a lot of our major psychiatric illnesses have a genetic predisposition. Psychosocial stressors, if you remember back, sometimes we have, we only look back on our childhood and think of the happiest times, or we have maybe a way of looking back where we think, oh, back then it was so good. We didn't have bills, we didn't have a mortgage, all the kind of pressures that you have in your adult life. But, there's significant stressors growing up. You don't have power in your life. Bullying, it can be a big one. The peer pressure, especially in adolescence, worrying about what everybody thinks of you. And just to go back to the bullying a little bit, there's a lot of times in classrooms, it's like the kids take turns, focusing on one kid and making them the scapegoat that everybody looks down on. And that kind of jumps. It's not always usually the same kid. It goes from kid to kid. And so those are, trying to keep out of that is very, very, it's crushing to be the scapegoat of the class and to be the one everybody makes fun of. Academic pressure, when I was young, when I was a kid, your grades before high school didn't matter so much. I mean, you would take these standardized tests, and that kind of put you in a classroom with other kids of your same abilities. So there was pressure there, but we weren't even aware of that. We just had these tests that kind of came out of nowhere. And so there's academic pressure that's starting earlier and earlier these days with kids. Um, and then having a mother that has a psychiatric illness seems to really be hurtful. Just because our mother figure is the one that, is the kind of grounding force in your life, it's very difficult when the mother has a psychiatric illness. It's also difficult with the father as well, but from what we see, the mental illness of the mother is the more devastating impact on the child. All right, so bullying, that's been in the news a lot lately, and it's very painful. It, you can see here, about half of the kids in school say that they've experienced it at some point or another. Um, it kind of teaches you this power, power-based relationships and dysfunctional communication patterns. It can really set you back socially, emotionally, and academically. And it's hard to learn when you're under that kind of psychological stress and those kind of feelings. One thing to be aware of, though, you won't see this as a diagnosis. It's not a formally recognized psychiatric diagnosis. It's a psychosocial stressor, and so that doesn't mean it's not serious, but it is. It's not a. You just need to know that for NCLEX and for if you ever see that on an exam. It's not a diagnosis. It's just it definitely is a risk factor, though. All right, so other childhood issues. We have oppositional defiant disorder. Now, this is a kid that's acting out, but they really don't violate the rights of other people. This is the typical adolescent that's they're defiant. They talk back. They argue, but they're not. They don't beat people up or sexually assault other kids. Um, these are the kids they kind of want attention. They want it, especially from the other kids. Um, they like to have like a radical hairstyle or a lot of piercings or tattoos that might be found offensive. Um, but they don't violate other people's rights. They don't, they're not victimizing people. Okay, so the conduct disorder does victimize people. They This is kind of a pre-antisocial personality diagnosis. These people can develop into criminals, um, and they do violate the rights of other people, including their peers. These are the adolescents that might try to sneak medications into somebody's drink at a party and then rape them when they're unconscious. Um, these are the kids that are the worst bullies that really get into a lot of fights with other kids, and they generally choose kids that are much smaller so they are sure that they win. Um, Most bullies are you know kind of deep down they're cowards. They only want to fight people they know they can win easily. And then they torture animals and insects. These are the kids that we worry about with very especially small animals that are very vulnerable. The family pet is the big target. Um, kind of the start off is, kids will learn usually from other kids that you can, with a mirror, you can reflect the sun and you can reflect it onto insects and make the insect catch on fire sometimes. And this is something that a normal kid might discover and play around with and then, leave it alone. It's just kind of like something, a science, something that's interesting. But the kid with conduct disorder is going to really enjoy the torturing of the insects, and that's the start. So the family pets are really in danger, and this is the kid that does victimize other people, and anything victimizes animals, and of course insects. So nursing care for someone with conduct disorder, it's not easy because there's no real effective treatment. The kid with nursing care the kid with conduct disorder does not have empathy for other people or, other life forms. And so, with most kids, if they've done something bad to another kid, you can try to get them to see how would you like it if somebody did that to you? That's kind of a common parenting technique. Would you like it if you got pushed into the bushes? That doesn't work with a kid with conduct disorder because they don't have empathy for other people. And, if it develops into the adult version, which is antisocial personality, they really they don't identify with other people in a larger way. They don't, they don't have any empathy or even kind of see themselves as similar. They see themselves as separate. And so really the reason why with the adults that have antisocial personality, they're the reason why we have prisons and, we have places to put people to protect society from them. They need consequences. That's the only thing they respond to with conduct disorder. So behavior modification techniques that, if you engage in this behavior, this is the consequence. You can't talk your way out of it. This is going to always be the consequence, and it always is. And those consequences have to be routine. You have to be able to give the consequence without being emotional upset. It just has to be matter of fact. If you do this, then this is what happens. And if you allow any kind of manipulation around that, it's all out the window. It's not going to be an effective consequence in the future if they know they can manipulate their way out of it. All right, so basically, what else helps? Like you see on your slide here, the anything where you can increase their self-esteem when they're feeling worse about themselves. That's when they're the most brutal in their treatment of other people and other life forms. All right, so another major category of psychiatric illnesses in childhood and adolescence is anxiety disorders. And so they can have multiple fears. We have one, separation anxiety, where if when the parent leaves, especially the mother or whoever's the primary caretaker, there's child just falls apart with anxiety. Can't go to school. Enuresis, that's wetting themselves, urinating on themselves. Yeah, so anxiety is there is a genetic component to anxiety disorders, and so if there's that in your family, there's anxiety disorders, the genetic component, it doesn't always look exactly the same in the child, but it has the same feel to it. So somebody's an adult, they might have OCD, obsessive compulsive disorder, where they're cleaning and everything, but their child might have, you know, the more anxiety disorders that are focused on that kids have, traveling, refusing to go to school, can't handle it when their main caretaker is leaving. So anyway, some other things, if they've had some kind of other stresses, like they're a premature infant, or they're victimized by a bully, or they've been abused, those put you more at risk for anxiety disorders as well. That the whole getting sensitized to cortisol, the stress hormone that's released when bad things happen to us. That makes you more prone to developing an anxiety issue. All right, so some interventions: teaching them how to solve problems in a logical way that's more about the problem and less about them. So like every time they're challenged by something, they're not it doesn't have to do about them personally. It's about the situation, how to think through a situation. And when they are successful thinking through those situations, you want to give them as much positive feedback as possible. So when they're, and this goes for all interventions with kids, when a child is behaving the way that you want them to, you want to give them as much positive feedback as possible. You want to reward that behavior. One of the problems we can fall into as parents and caregivers is that we only pay attention to them when they're doing something that we're trying to correct. And so, we want to stay away from that, and we want to make sure that we're giving them attention when they're doing what we want. Because remember, your attention is what some kids really crave. That's the biggest thing you can give to them, is your attention. Okay, and then any interventions that increase the child's self-esteem. You won't see a child with high self-esteem and then they have anxiety disorders. Anxiety always goes with low self-esteem, and it makes sense. If you think one of the big issues with self-esteem is, do you feel like you can handle whatever's going to happen to you in the world? If you have low self-esteem, you don't feel like you're not confident in yourself that you'll be able to handle whatever comes up. So anything we can do to increase their self-esteem. And just on a general note with children, the current generation of kids, sometimes parents give them way too much positive feedback on things that are well, let me rephrase that. The kind of feedback that you want to give your kid, you want to give them feedback on, you don't want to tell them, like if they draw a nice picture, you don't want to compliment them on their brilliance as an artist. That doesn't help them in the long run. What you want to compliment them on is the effort that they put into it. You always want to praise their effort, their determination to overcome obstacles, their ability to keep working hard in the face of frustration. You don't want to praise them for talents, because then it kind of creates an unrealistic expectation of the future, unrealistic view of themselves. And sometimes kids feel like if they don't have a talent for something, they'll stop trying. And so you always want to emphasize their efforts and their trying. Probably for those of you, for most of you, you weren't like a super talented student in all of these science classes that led to you getting into nursing school. You had to work hard, you had to overcome obstacles, and you had to endure. You had to have stressful times in which you doubted yourself, but you performed, and you performed in the face of stress anyway. And so those are the same qualities that a child needs to be successful in life. All right, suicide is especially sad when it happens with a young person. It's the third leading cause of death among young people, and that's a little bit misleading because it's passed up automotive accidents, and part of the reason for that is because cars are much safer than they used to be. But it is, kids today, they're with a lot of great things came out of the invention of the internet, but there's also a sense that everybody is kind of like their own celebrity. Everybody has an Instagram. They have, whatever the new social media app that comes out with. They might have a YouTube channel. I've admitted kids that, to the psychiatric unit that have their own YouTube channel where they review toys and they actually make money from it. And so kids kind of have this it's like everybody is a celebrity in the culture these days, or can be. And so that puts you at risk for it just gives you a weird, unrealistic view of yourself, and makes it where your ego is, you're not really ready for that kind of attention when you're a kid. Most people aren't as an adult either. So I think that's why there's more suicide these days with kids and teenagers. So we have our LGBT. I guess the proper would be LGBTQ plus youth are 2 to 3 times more likely to attempt suicide, and it's very stressful. We're a little bit spoiled. It's a little easier here for us in the Bay Area because our culture in this area is a little more accepting than most of the rest of the country. But it's still a very stressful thing here. And what really is a big stressor is they sometimes, if they feel like especially their parents are not going to accept it, whatever they are, if their sexual orientation, if they're not straight, or if they feel like they're not the gender that they were born into, it's especially stressful if they think that their parents are not going to accept it. And I've admitted multiple adolescents that really the only reason why they're suicidal is because they think their parent is not going to accept them. Yeah, and sometimes, as a nurse, you're admitting someone, and I'll just tell you about one girl I had that that was her issue, and I talked to the parents, and the parents kind of suspected that she might be a lesbian, and they said they would be fine with it. They don't care. They just want her to be okay. And they had no, they were kind of, at least they presented themselves, and they said they're not, they're not anti-gay. They're accepting of other sexual orientations and everything. And still, it was very hard for this young girl to tell her parents that she was gay. I tried to get her, I said during the admission interview, look, I just talked to your parents. They seem like open, accepting people. Do you want me to invite them into the interview and, we'll tell them together? And she said, no, she's not ready for that. And so, yeah, so it's a very stressful thing, a very, very significant barrier, and does lead to a lot of suicides in our teenagers. All right, and then somebody that's the victim of bullying is remember, it's extremely stressful, and especially if it's an ongoing thing, and they're the scapegoat of the class, and it goes on and on and on. And the bullying can be, they can go online and say mean stuff, in their social media. Um, we've even had kids that create a whole, little social media profile just to be mean to one kid, and then all the kids join it and say their mean stuff to about that one kid that's being scapegoated. And it's overwhelming for when the kid that's being scapegoated discovers that. And so kids can be really mean to each other. It's shocking sometimes. All right, so the overwhelming feelings, just like with adults, they feel trapped. Um, Many times that they're just wanting to escape the situation and don't know any other way. Um, One of my big suicide assessments for a child or a teenager, that might not sound to you like a suicide assessment question is I will ask them, what do you want to be when you grow up? And you know, if they have an answer for that and it's like well thought out, especially with the depressed suicidal teenager, if they can tell me, oh yeah, I want to go to college, I want to do this or that, then I know that it's a little less serious. But if they tell me that, I haven't thought of it, I don't think I'm going to still be alive then I'm very concerned. Um, so anyway, what do you want to be when you grow up is a suicide assessment question with children and adolescents that have been having suicidal feelings. So a future focus is definitely one thing you want to try to see if your patient has. So, like we talked about at the start of the slideshow, a lot of kids and adolescents have never sought treatment, even though they have some major depression, major psychiatric issues. And so, what we find on kids that have completed a suicide attempt is most of them don't, they were never diagnosed with a serious psychiatric issue. And one of the really terrifying things when you're a parent of an adolescent is that, you know, adolescents, they don't have the experience that we have as an adult of going through a really tough time. And, sometimes when you're going through a crisis in your life, you don't have to do anything heroic. Sometimes just waiting, just time, and the situation resolves itself. But remember, when you're a kid or a teenager, you don't have a lot of life experience. So you don't have that experience of going through a time where you can't see any way it's going to improve, and then it improves. Um, and so sometimes, adolescents and kids, they'll make an impulsive decision to make a serious suicide attempt that shocks everyone in their life because there was, the child may have never talked about being depressed, never expressed any suicidal feelings. This can be really hard for parents to take and to accept because they'll want to say, they'll not accept it and believe that the child was murdered and it was just made to look like a suicide. Just because it's really probably the most painful thing for a family is when a family member kills themselves, and especially a child or an adolescent. There's a lot of a lot of guilt. What did we do wrong? What could we have done better? Um, you know, a feeling of how bad could we have failed as parents that this child took their own life. And so there's a lot of pain there. All right, so another thing that's really common, especially with adolescents and especially with adolescent girls, although I see it more and more with boys as well, is wanting to cut on themselves. And the whole self-injury by cutting's not the only thing they do. They also kind of they can burn themselves, they can bang themselves, bang their head on the wall, they can, hit themselves with their fist. But generally this kind of self-injury, and cutting is the most common, is like a way to relieve some pain, relieve some feelings. And the cutting sometimes leads to a little feeling of euphoria. And so that's kind of like a way to manage feelings. It can be a way of trying to draw some attention to show other people around you that you're in pain, especially if it's done in a place where it's really visible. Like, the most common is on the forearm of the non-dominant arm. If they're right-handed, they tend to cut on their left forearm. A little more worrisome is when the cutting is on, in areas that aren't visible to, not easily visible. On girls, they do it a lot on their hips and on their thighs. And that's a little more worrisome because they're trying to hide it. They're doing it in a place where nobody will notice. And so, still when I'm admitting a child onto the psychiatric unit that has that, I'm not overly concerned about it as long as it's superficial cutting. And with superficial cutting, it's a little beyond scratching, I guess, but it doesn't require medical treatment. And it tends to be done repetitively. You'll see it, their forearm might look like a road map, if you remember what a road map looked like. Tons of little, there might be 1,000 superficial cuts on the forearm, but none of them are really even draw much blood or anything like that. So they don't require any kind of treatment. Maybe a little, you can put some antibiotic type of ointment on it if it's a little deeper, but generally doesn't require any stitches or sutures or anything like that. That we don't consider that a suicide attempt. We consider that just self-injury. All right, so mood disorders. So when we talk about mood disorders, we're talking about like depression, bipolar disorder, which for children we don't call it bipolar disorder anymore. There's a new diagnosis for that we'll talk about on a future slide. But causes of mood disorders in kids, there's the stuff that happens to you in your life. One of the things about being a kid is you sometimes don't have control of things. So there's something in psychology we call learned helplessness. And what we mean by that is, in your life, things happen that are not in your control. And it becomes learned helplessness when you get to a point in your life where things are in your control, but you're so used to it from the time in your life when you didn't have control that you still don't make any changes. You still respond to it the same way. That was a concept that was put forth by a psychologist named Martin Seligman. And one of the things in research that was a significant thing about learned helplessness was if you have like a goldfish bowl and you have these large goldfish and then you put tiny little fish in that the goldfish would normally eat, but you put it in the middle of the bowl and you have them in a see-through container where the goldfish can see them, but they can't get to them because of that container. the goldfish will try to get them and then they can't because there's that barrier. But if, what psychologists find is, if they're in there for a couple of days and then you take that barrier out, where now the goldfish should be able to eat those little fish, they don't, because they've kind of learned that it's, they went for it so many times when they thought it was available and it wasn't, then, and they were blocked, that now that that barrier is gone, they don't realize it and they still don't eat the little fish. And so that, they kind of put that forward and look at a lot of things in life, and it's a significant issue for a lot of people, not just with kids, but in our lives. Things that we kind of grew to accept when we were at times in our life when we couldn't change. Now that we can change them, we don't, because we kind of learned, we still have that feeling of helplessness around it, even though we're not helpless anymore. So other thing with mood disorders, there is a genetic component. Remember with the major ones, like bipolar disorder, having someone in your family, especially, the closer the relative is to you, as far as how much of the gene pool you have with them, you have a much higher risk to develop that mood disorder. All right, so interventions for mood disorders, family therapy to help the parents manage it, always assessing for suicidal feelings. Any kind of drug use, sometimes alcohol and drug use, that can happen for kids that are trying to manage their feelings. If they have a mood disorder that makes them have an elevated mood, then they might find things that keep them calmer, but that leads to problems in the long run. And what I have in the parentheses here, it can be a sign of sexual physical abuse. What we're talking about is kids that are escaping reality by using a lot of alcohol and drugs, especially at a very young age. They can be doing that to try to keep themselves numb. And so that's something you always want to assess when you have especially a young adolescent, like a 14-year-old that's drinking large amounts. It's just one of those things we always assess it, but especially look a little closer. And then we can use medications for kids as well. Sometimes people are a little scared about giving their meds to kids. One of the things that we see a lot where, kids will have a dose of a medication that's the same as an adult, even though they're much smaller. One of the things to know about children is they metabolize drugs a lot faster, and so they really don't have the same dose of, just an example, say a Zoloft 50 milligrams dose. That's a lot less of a dose. It's going to be metabolized a lot faster in a child than it will be in an adult. So a parent that thinks, well, God, I'm 200 pounds and my 70-pound son is on the same dose of antidepressant that I am. Isn't that too much? That's one of the things that you want to educate a parent about. Sometimes those, kids, they metabolize the medications a lot faster than adults, so it really isn't the same dose. The same dose is not circulating in the child's bloodstream as it is for an adult. All right, so this is our it's a new diagnosis that's replacing pediatric bipolar disorder. It is very similar to what you see in adults. It's kind of adjusted for children. And the big thing about this one is the kid that has severe temper tantrums, and it's not about one setting. It's three or more times per week for at least a year, and so that's a lot of temper tantrums. This isn't just a kid that's having a bad week. This is a kid that does this a lot, and it's 3 or more times, so 3 is the minimum. So they could have a temper tantrum every day. And the big thing is it doesn't just happen, it doesn't just happen at school where they're having a hard time at school. It doesn't just happen at home where they're having some kind of problem with their parents. It happens in, wherever they are, in different settings with different people supervising them. So it's not a conflict with any particular parent or anything like that. Um, yeah, so this is one of our new diagnoses. You'll hear them call it DMDD. And that's why when a new DSM comes out, it only comes out about every 12 years or so, maybe 15 years, depending on kind of what the need is in the field or how things are trending. Um, but when it does, it usually has some significant differences. And so if you do specialize in psychiatric nursing, you want to, when a new DSM comes out, you kind of focus your continuing education on that, and you want to make sure you know what's changed in it. All right, so another thing that changed is autism spectrum disorder. This changed in the DSM-5. Um, we no longer use the diagnosis of Asperger's. Um, and so with autism spectrum disorders, they're kind of all in the same thing. And then you say if they're high functioning or low functioning. And so autism was generally what we considered, we used to just call it autistic, but now it's autistic with problems in the speech, and so that would be the lower functioning autism spectrum disorder, also called ASD. If you hear that, it'll be shortened to ASD with people that are in the field all the time and dealing with it a lot. So with autism, you can frequently see it before 3 years old, and you can see it even in an infant. Sometimes you can notice that the infant is not connecting. They're not doing the kind of peekaboo games. They don't respond like that. Anybody that's had an infant in their life, you know that they communicate a lot, even with their facial expressions. They respond to your facial expressions and your tone of voice. But you don't see that as much in a child that's going to have autism spectrum issues. They're not as connected. They might not be connected. They might not seem connected to you at all as a parent. And so sometimes this doesn't get diagnosed very easily. Usually people that have had a child before, they recognize it early because they know it's normal for a baby. But this can go unrecognized for a long time, especially if this is the first child of the mother. All right, so what we now call the higher functioning autism, it was called Asperger's before the DSM-5. And so, if you hear the term Asperger's, that's really an old term. If you see that on the NCLEX, just think that it's an old question that nobody thought to take out of the NCLEX, but you just want to think of it as high functioning autism. And so basically the difference between Asperger's and low functioning autism is that the people with the high functioning autism spectrum disorder, they're able to speak, they have good language, they have, their thought is good. What we see a lot is people with high functioning autism, they have trouble with emotions. They have sometimes can be violent because of anger management issues, impulsive anger. A lot of that comes out of not being able to read social cues, and they tend to be very good at technical things. A lot of our computer science experts are real, really great tech people are actually high functioning autism spectrum people. We our geek squad, if you if you heard that term before, I think that's one of our stores uses that term for our people that go out and they help you set up your systems for computer systems and televisions that are complicated. Um, so these people are useful in society. Sometimes there are some of our best engineers, our computer programmers. Um, some people have said that, the person that developed Facebook is somebody that would qualify for this diagnosis. I don't know that that's true. I don't know that person personally. But I do know that a lot of our great computer people that are beyond the normal, they have skills in that because of this particular tendency. And so it's not good for them. They're not good socially, but they're excellent with these kind of machines, and it is something that does improve our life, and so that's why it's good to have a diversity of people. It's it's good that they exist. They advance our society, but they can struggle with a lot of relationships and connecting to other people. They're really have a hard time with that. And like I said, they can be a risk to be violent. All right, attention deficit hyperactivity disorder, ADHD, and you can see this is really hard on a kid's self-esteem. This is a kid that gets in trouble. That is the kid that the teacher is angry at because they won't sit still, or they talk all the time to the other kids. They interrupt the teacher. They interrupt the class. And that can set off a whole thing where the kid that gets in trouble with the teacher, they might, you know, it doesn't sound adaptive, but kind of an adaptive thing for their ego is to be the kid that makes the other kids laugh. And so, yeah, the teacher might hate you, but if you can be the hero to the other kids by being the class clown, and that can be a source of self-esteem for the kid and also get them in more trouble. And so these are the challenges that we deal with. Um, ADHD was changed a lot as well. For ADHD, for the DSM-5, one of the things that the changes made in the DSM-5 was they took away ADD. There used to be attention deficit disorder was a formal DSM diagnosis, and what it was basically was the same thing, but it didn't have the hyperactivity component. It only had inattentiveness. And so if you hear the term ADD, realize that's out of date now. The new terminology is to call it ADHD and then inattentive type for somebody that would have just been called attention deficit disorder. One of the changes in DSM that I don't know, I kind of feel like it made it a little less clear because there's a lot of people out there that have been diagnosed throughout their life with attention deficit disorder that really just can't pay attention and really don't look anything like the people with ADHD. The classically ADHD. The kind of ADHD that most people think about is what you see on your screen, B or C, where there's a hyperactivity component to it. They're very impulsive. They can't sit still. That's the kid that's in trouble with the teacher all the time. And then they can also be combined where they have hyperactivity and inattentiveness, which makes it really hard. And so yeah. So anyway, just to summarize, so the correct term for attention deficit disorder, that diagnosis no longer exists. In the DSM-5, the correct diagnosis for somebody that used to be called attention deficit disorder would be ADHD inattentive type. All right. All right, so this is typical typical kind of things that are going on with someone that has ADHD and attentive type. Um, I'm not going to read it all, but it just kind of looks, you can take a look at that for a second. Most of it is probably obvious if you're aware of these kind of issues. The hyperactivity problem for patients with ADHD, um, hyperactive impulsive type, just like we said. And this phrase here looks like they're driven by a motor. That really is how it looks. It's like you tell the kid to sit down and calm down. It's almost like they're a bipolar patient in a manic episode, if you know what that looks like. It's like that kid does not have the capacity to sit down and be still. Um, you're asking them to do something they're not capable of, and they're going to fail at that. And it's not that they're being defiant necessarily, it's that they just can't help it. They have ADHD. Um, all right, so the prevalence, 3 to 5%. Males have more problems with this than females, especially the impulsive, hyperactive type. Um, more problems in families with psychiatric disorders, and sometimes people with ADHD, it seems like they're diagnosed with bipolar disorder later on in their life. It's a little unclear if they really had ADHD or if they had some of those bipolar elevated mood issues as a child that just were not correctly categorized. Um, and the statistic at the bottom here, it's from an older article, but you can imagine the hours of TV viewed per day. Nowadays, kids are, one of the ways to get a little peace and quiet from your kid is to give them an iPad or something like that, where they can watch their movies or so we're starting kids with screen time very early in their life, and so you can imagine their problems paying attention, um, and being able to tolerate frustration and to be able to wait. Those abilities don't develop when kids are in front of a screen so often early in their life. All right, so the other main thing with ADHD is the impulsivity. So they'll blurt things out and they interrupt. They can't, one of the big things that I remember in my early childhood, first grade, second grade, there was a lot of emphasis placed on being able to stand in line, to line up correctly when the recess was over to come back into the classroom. Um, it was highly valued by the teachers of that day. I think it probably is these days as well. And part of that is they want to socialize you, make you able to function in society, and they want to get you more out of the recess mode and into kind of a mode where you can be appropriate socially before you walk back into the classroom. But a kid with the impulsivity problems, this is a kid that wants to be first in the line, and then when they're not, they push people. They have trouble with the whole standing in line before returning into the classroom. All right, so like I said earlier, ADHD, you can see it in the first weeks of life, just like with the kid with autism. Um, and this is a kid that will connect, but they don't maintain it if they have the inattention issues, or they're all over the place if they have the impulsivity and the hyperactivity type of issues. And so that they might not sleep very well. The cause, it's not quite clear, and you can see genetic there, but we haven't As far as I'm aware, we haven't identified any particular gene clusters that go along with ADHD like we have in other of our major diagnoses like schizophrenia and bipolar disorder, but there is thought to be a genetic component there. Yeah, and the abnormal rates of brain development, those kind of things are it's very difficult to measure brain development in people that are alive because of the cerebral spinal fluid that's in the brain. But it is thought that the frontal lobe develops later, and the frontal lobe is the part that allows you to control your emotions, and so that's why that would be significant. All right, so inattention. Let's see, we had a slide on that a little bit earlier, but you can understand what inattention is. Hyperactive. So nursing care for ADHD, so especially if they have the trouble paying attention, not having them in a lot of stimuli helps. The kid with a problem with inattention, that's the child that you want to have sitting in the front. You don't want them sitting next to the window because they're going to be staring out the window and not paying attention. So they shouldn't be in the back of the room where there's a lot of distractions. They should be in the front of the room, especially with the inattentive problems. With the hyperactive problems, that's hard because if you put them in the front of the room, they're more distracting to the teacher if they're unable to contain that. It's important to teach the family. There's a lot of teaching around the meds, but we also have to teach them to really foster the self-esteem in these kids because all of these problems are worse with low self-esteem. And then parenting skills. Make sure parents are, when there are punishments for the child, that they're very clear that the punishment is for the behavior and not where the child feels like they're just bad. And then there's, for parents that are really, really scared about their children being on medications, there is an alternative called neurotherapy. Probably not the only alternative out there, but where the idea is the child is hooked up to an EEG where it kind of looks at your brain waves and then trained in different methods how to kind of manipulate and have certain brain waves be the ones that are how to think to get the brain waves that are most effective for being able to pay attention and being able to control your hyperactivity. Now, this is something that's been out there for a long time. There's research on it, but I was just reading an article on it this morning. There's not really a good protocol out yet that tells exactly what should be done. In fact, there's research on it, but it doesn't all come together in terms of having anything that can be officially recommended. So just from my little look at the research, this is something it's been around for a long time. It generally has been thought of as pretty ineffective, especially compared to medications. But it seems like it has a lot of promise. One of the problems with it is it's expensive, and it has some of the problems trying to do this with a kid with ADHD is it really requires some attention to detail. And if you have a problem with attention, it's hard to learn from the start. And then it's also, if you can't sit still, you can't, trying to have a kid that's unmedicated with a hyperactivity issue sit still for an EEG, I can see that as a challenge as well. But there are clinics that specialize in this. There's one in Walnut Creek. There's individual practitioners that specialize in this. So if there's families that really want to avoid medications, there are things they can try. Just they're not really accepted as well, at least not yet. And they're not covered by insurance, which can be important if the family doesn't have a lot of money to spend on this. And there is some promise for the future, though, and it has been around for a while. There hasn't been, if it didn't work for anyone, it would eventually have gone out of business, but it still exists. And so it's probably more effective for somebody as an adult that would be very highly motivated to not be on medication, or for some reason can't tolerate the medications for ADHD. All right, so our ADHD medications, and the big ones, psychostimulants, those are usually the most effective. And some of these are probably not on the med list because I tried not to have too much on there. The big thing with psychostimulants is they can stunt your growth as a child, and so it's important to teach the parents to check their height every 6 months and their weight every month, and just to know that it can affect the blood pressure, and so they should buy they should own a blood pressure cuff, and they should you want to make sure they know how to use it, and just from time to time do a blood pressure. And what you would worry about is that it might be elevated, and probably parents are not going to be very good at hearing palpitations, or palpitations. But if you're seeing a child that is on a psychostimulant, you want to listen to their heart, make sure there's nothing amiss in their heartbeat. All right, so we do have ADHD medications that are not stimulants. Our big one here that's FDA approved for ADHD is Strattera. It's the first one that was FDA approved for ADHD that's not a stimulant, but it does have the issue of it can sometimes increase suicidal feelings, and so you wouldn't want somebody to be on this that had any kind of history of being suicidal. So some other strategies for ADHD medications, and these are things that they're not necessarily FDA approved, but they're used off-label for ADHD. So we have the different blood pressure medications. The thing you see most often that's used for ADHD is 10x, which there's a long-acting version called Intuitive, which lowers the blood pressure, keeps it keeps it under wraps, keeps it contained. And the idea with that is if your blood pressure can't go up very much, then it helps, especially with the hyperactive component. Those of the with ADHD, that's the hyperactive type, can benefit from this. And so 10x, Intuitive is not the only one. The other cardiac medications that keep blood pressure in check, like mini press that we also use for PTSD, that can be used as well, along with almost all of the class that are beta blockers in your cardiac medications are used for off-label for ADHD as well. And like I said, primarily the hyperactive type. Then we have Wellbutrin, can be used as well. Remember Wellbutrin, it's an antidepressant, but it also has been found to be effective for ADHD. All right, so childhood disorders, nursing interventions, just some basics, behavior modification, and that's basically rewarding positive behavior and not rewarding negative behavior. The big thing with behavior modification is making sure that you're giving a lot of positive feedback when the child is doing the behaviors that you want them to do. And the traps that we fall into as parents is that we ignore them when they're doing well, and then we only pay attention when they're doing things that we want to correct. Well, that's the opposite of what you want. You want to give them your attention when they're doing what you want them to do, because your attention is a definite reward. So our other things, medications, play therapy. This doesn't mean just playing with the child. It means the way that children, especially young children, interact with the world is through play. And so when and just to give you a little something from my life as my prior life as a psychotherapist, when you're doing therapy with children, you really do see how they interact with other children in the world. Some of the things that you look for in play therapy are do they communicate well when they're playing a game with you? Do they try to cheat? Are they overly competitive? Um, do they talk a lot of crap when they win? Do they make the other person feel bad when the patient when they win the game? When they lose, do they fall apart? Do they are they bad sports? Do they turn the game over and march out? Do they accuse you of cheating? Do they, at the end of the session, do they want to take all the toys home from the play therapy room? Do they, if they don't have this little army man, if they can't take him home, then they fall apart. All of that, you can see that just doing play therapy with children. One of our big tools in play therapy is sandbox. There's a sandbox where, if you've ever played in a sandbox, you can make the sand wet and you can create little things in it. And so there's a whole field around play therapy with kids around working in the sandbox where there's a belief that, kind of we recreate what's going on in our unconscious in the sandbox with our, whatever kind of things we set up. And so there's a whole, therapy around that. So family therapy, educating parents how to be, about all of this and how to facilitate the changes they want in their kids, how to communicate, goal setting groups. Sometimes with adolescents, the group therapy can be very challenging because adolescents that connect with each other so dramatically. I've heard therapists say that group therapy with adolescents isn't good, but what I've seen in my practice on the psychiatric units is that it is good. You just have to structure it really well. And if there's somebody trying to sabotage the group, you have to focus on that. So it takes a lot of activeness of the group leaders to make sure it doesn't go awry. And then substance abuse treatment if they have substance abuse issues. All right, so our basic developmental issues of adolescence, they're going from being totally dependent on parents to being able to be independent. And so a lot of the pressure between parents and children, especially adolescents, is the adolescent is going to, naturally push for more independence, and the parents, have to kind of let it go a little bit, but not too dramatically. They still have to supervise their kids, and it doesn't, it's not static. It's like it goes from time, it varies based on what's going on and what the situation is. There's some kids that can be really responsible and then go to a party and be really irresponsible. And so as parents, it's really hard to try to manage that. There's going to be a natural tension between an adolescent pushing for more independence, and the child trying to keep, and the parent trying to keep them safe. And so something we call in the field the rubber fences concept. You want to encourage parents to have a parenting style. First of all, you want them to feel like you can handle any problems that they have. And if you want your child to be able to come to you with, if there's something bad happening to them, like they're being abused or they've been raped or, something bad, but even minor problems, if you want them to be able to come to you as a parent, you can't fall apart. You have to show that you can, you can be okay with it. So you want them to be able to come to you and be more of a consultant than somebody that's like telling them what to do. We call this kind of like a rubber fences concept. So what that really means is the adolescent, when they run into a barrier, it shouldn't be like they're running into a brick wall. It should be like they run into a rubber fence that might give a little bit, but then snaps, kind of pushes back on them. Gives a little bit, but doesn't allow them to crash through it, or to be like a brick wall where it would just, if you run into it, it just obliterates you. And so yeah. So the rubber fence is what we mean is the limits shouldn't be unbending. It shouldn't be where if the kid gets in trouble, they're on restriction forever. But they do need to be, have their restriction or whatever the punishment is. It needs to happen, but it needs to not be all or nothing. It needs to be not so rigid. And you have to, what's really hard for parents is kids need different things. They don't all need the same thing. You can have 3 girls, and each girl will have a different amount of independence they can tolerate at age 13. They'll have a different set of limits they need, and the basic thing is as a parent, you need to be able to be flexible. One of my pieces of advice that I really stand behind from my years of working in adolescent psychiatry with parents is this whole thing of your adolescents, when they're on the internet, the whole world of whatever's out there in the world can access them in certain ways if they go onto certain websites. And so what you want to establish with your adolescents is that that you can be on all these different sites, but just know I have to have all your passwords, and from time to time I'm going to go in and look at what you're doing. It's just a basic thing of how to be a responsible parent and supervise your child, your adolescent. It's just basic supervision. You need to and it needs to be where the adolescent knows this. And the problem I've seen time and time again is where parents are like, oh no, I trust my kid, they would never do anything bad, or and then they go in and the kid, thinking that they have privacy, kind of falls into some of the things that kids fall into, sending naked pictures of themselves to each other, or even to adults that try to prey on them on the internet. And so, and then the parents like lose it, and then the kid feels the parent has betrayed them by giving them the idea that they had privacy and then violating that privacy. No, that's why it's really important that you're upfront with the kid and say, listen, It's a crazy world out there. It's not that I don't trust you, it's that I don't trust the world. And I have to be able to come in and, look at what you're doing on the internet. I need to be able to look and see what's in your photos. Um, and I need to have your passwords to your sites. I need to know all of this. Um, and that has to be above board. It can't be like parents sneaking, don't, you're kind of setting yourself up if you do it that way. And it's not fair to the kid. All right, so that kind of leads into sexuality. So I don't know how many of you remember for some of us, adolescence was a long time ago, but um, the changes that are happening to your body, it can feel dramatic. Um, you know, you feel like you're morphing into something different, which you kind of are. You're morphing into an adult from a child, and all the hormones and all the things that are going on can be quite confusing. When we talk about kids around their sexuality, we want to try to help them understand their value system and develop that and value that so that they don't in the face of peer pressure, they don't give up their value system, and then they feel bad about it later on. Um, yeah. Teen pregnancy. So teenage pregnancy is a huge problem in this country with the regulations that are coming forth now on restriction of things like abortion. It's going to get worse. Um, and so anyway, the risk factors for sexual abuse, low income, all of these are risk factors, and the consequences. Most of the time they don't get a high school diploma. There's a lot of programs these days that help kids get through. Sometimes those programs, they're too focused on getting the kid through and not enough focus on, actually educating them. And so sometimes they'll get through with some kind of, they might get their diploma, but then they're not ready for, any other kind of higher education. Um, Teenagers, they're not ready for this, so they're probably not going to get adequate prenatal care. And sometimes they're not aware of it until later on, and then they don't disclose it for a long time because they don't know how people in their life are going to react to it. Teenage mothers, they're why we have these safe surrender sites where you can go, and we have it at Herrick, the security desk, where if somebody has a baby and they don't want the baby, they can bring it in and give it away without any questions asked. And the idea behind that is we don't want babies being abandoned in dumpsters. It sounds horrible, but it's happened multiple times. And so we as a society, we don't quite know how to deal with this. We're not very good at it. But we do know that we don't want babies abandoned in dumpsters. So we do have the safe surrender sites where they can leave a baby. It doesn't have to be a teenager, but that's primarily the idea behind those. Is it's somebody that has a baby that really doesn't want it and is not prepared to care for it. And we want them to give it up, not not do anything that's going to cause harm to the baby. So 60% of teenage mothers, they'll live below the poverty line later in their life as well. And it's hard. It's very hard to get started in the world with a baby. It's not as bad as when I was young. When I was young, my sister had a baby when she was 16, and she probably wasn't going to go to college anyway, but anything that you had planned is now going to be much harder. I know there are some people that have probably in the nursing program that have had babies as a teenager, and if they got through it, it's just incredible determination and being able to use resources and usually some help from other family members. But especially if you're a single mother that has a baby, it's very difficult to get forward in life, especially if you don't have any kind of way to make income. All right, so like we said, if you give birth as a teen, you're twice as likely to be living in poverty later in life. One of our big things we need to teach teenage mothers is to read to their child, and that's a strategy to make sure that child doesn't grow up and repeat the same kind of problems if it does turn out that the mom came from poverty, and that's one of the things that contributed to her getting pregnant as a teenager. And basically what you do is you teach the mom to take their kid to a library, and generally you can check out about 10 books a week, and you have not only it's just learning to read, but it's the fun of going to the library and choosing something new, and it's free as long as you return them on time. And so that's a routine that we want to teach all mothers, but especially teenage mothers, to read to their child before they go to bed. It's a nice little bonding thing. It it helps the child have less anxiety in it and more of a connection to their parent before they fall asleep. Um, yeah, and it's one of the ways we can really assist teenage mothers in understanding how to care for their child. All right, and then we there's always programs to help teenage mothers stay in school, and teaching parenting skills, which is something that should be more. I don't know how it is these days in high schools, but I know when I was in high school, there was no parenting skills taught. Even though I had sociology and other kind of social science classes in high school, I don't remember any parenting skills that were ever taught. All right, so moving on to eating disorders, our big ones here, anorexia nervosa and bulimia nervosa. Some of our big medical complications, amenorrhea. This is the where you no longer have a menses, or you no longer have a period, and that goes away because your body is focused on survival, and so the first thing that goes away is your ability to reproduce, because that's not necessary for your survival. Um, Calcium deficiency, and from your anatomy and physiology that you can't maintain, you can't have a good heartbeat and you can't have health without calcium. The body can become so depleted, especially with anorexia nervosa, where your body, when there's not any more fat to burn, when you're at a calorie restriction, your body will start to break down muscle to digest, and it even gets bad enough to where it starts to break down the muscle that's part of your heart, and that leads to your heart not beating correctly, which is dysrhythmias, which is one of the common reasons why people with anorexia nervosa have a heart attack, and they can have that at like a heart attack at 19 years old, very young. The electrolyte imbalances, we all know from not eating enough, a lack of potassium can definitely cause a heart attack, and arrhythmias that are very dangerous. And one of the things that really is striking is with all of our psychiatric diagnoses that are serious, like schizophrenia, bipolar disorder, major depressive disorder, our most lethal psychiatric diagnosis is anorexia nervosa. It's more than schizophrenia, bipolar disorder, major depression. Any of those are just the person that's starving themselves and can't really stop. And sometimes our patients with anorexia nervosa, they always think that they're not as sick. If they're on a psychiatric unit with other patients with different diagnoses, they'll think, oh, they're better than the other psychiatric patients. There's one that I have recently, an eating disorder young lady who she said, I feel like I'm the pearl in the clam, which I didn't quite follow that, but I did see that she thought she was like the special one, and everybody else was crazy around here. But I pointed out to her, well, your diagnosis is the one more likely to kill you. So really, who is the most crazy one? My patient over there that's talking to themselves, but they'll eat. They're going to live. They might be irrational. They might be manic. They might be psychotic, but at least they're doing what's necessary to live, where you're going to die. Anyway, those kind of confrontations don't work, but I do like to point out to anorexic nervosa patients that think that they're better than the other patients, this fact that they have actually the more serious illness. All right, so these are questions actually from our eating disorder assessment at where I work at Herrick, and these are kind of basic, and we're trying to ask them in ways that they can actually answer, that they'll answer truthfully. How much do you exercise, and do you have injuries from too much exercise? That's a big one. If they're exercising so much that they're getting injured, they'll see themselves as fat even when they're way underweight, and they only see themselves that. One of the things I've had students say before is if this little 5'6", 80-pound girl thinks she's fat, she must think I'm like a pig. But no, they don't see other people unrealistically. They only see themselves unrealistically. So triggers to their binging and purging: if they have bulimia, their BMI, their normal body weight, they're under 85% of normal. If they have anorexia nervosa, that's one of the diagnostic criteria. For bulimia, they're not necessarily underweight. They might even be overweight and have bulimia nervosa. So, we're going to talk about these in more detail, so don't worry if you don't quite understand these last two here. Russell sign is it's a callus. It's usually on the first knuckle of your dominant hand, and it's just from repeatedly using your finger to induce vomiting. And then lanugo, just like if you've ever seen the little hair on a baby, the person that's very underweight, they don't have enough body fat to keep in their heat, and so the body tries to adjust by growing this kind of soft hair to keep in some heat, and that's usually in somebody with serious anorexia that's had it for a long time, and it's not attractive. It's not something that you want. Sometimes the hair is on their cheeks or their face, frequently on the upper arms. Sometimes it's on the buttocks, on the cheeks of their butt. And so that is definitely not usually what they're looking for. It's not something that's a desirable thing that the anorexic patient is good for. And so sometimes that can be even a motivation that, hey, I'm starting to grow hair on my butt cheeks. Maybe I should look at this problem. That being said, anorexia nervosa, one of the famous quotes about it, it's the only life-threatening illness that patients are proud to have. They get a lot of attention in our culture. It really does a strange thing to females where it makes them all feel like they need to be super thin and very self-conscious about their bodies, and so it's the only life-threatening illness that they're proud to have. All right, so this is just a look at how anorexia nervosa affects the whole body. And you can see it there, and it makes sense. There's not a part of your body that can really exist without nutrition. So this is basically how they're thinking. Um, and the really sad part is, this little part of it here, if you can see my mouse, to be liked, I must be thin and I must control my weight and what I eat. The really bad part about that is that's not far off from reality. It doesn't, they are they are more popular if they're thin and they control their weight. And that's one of our problems in our society right now. We really glamorize thin people, especially if you're a female. All right, and so all of that kind of leads to constant talk about food and eating. One of the interesting things is a lot of times patients with anorexia nervosa, they work as waitresses, um, and it makes sense if you're obsessed with food and you're starving to want to be around it, but they still don't eat it. They just want to be around it. Um, that might be misleading as well because there's not a lot of options for young people to get employment. So sometimes being a waitress is just because there's not other better choices. Anyway, so you can kind of see how this progresses. And so, yeah. So this is kind of an extreme example of, this is how the person sees himself in the mirror. So body image distortion, and this is the body image distortion is primarily a symptom of anorexia nervosa. They're the ones that are extremely underweight. The way this girl looks, not the mirror picture, but the back end of her, that's what we call cachexia with a C, cachexia. And that's the person that looks like they're really starving. That looks like they've been in a concentration camp. They're so thin. All right, so our big physical symptoms related to anorexia nervosa, like what I described a moment ago, the lanugo, the hair growing to try to trap in some body heat. And this is an example on the cheeks of her face. She has it on her chin and then on the arm. Then we have what's called muscle wasting. And what it means is she's digested so much of her muscle due to the malnutrition that you can actually see her shoulder joint bone here. And so muscle wasting, it's all the muscle's gone. Okay, this slide is a great example of cachexia. And you can see how thin this woman is, and that look in her eye, that's a big one too. It's when someone's starving, they get this look on their face of this it's almost like a panic look in their eyes. This woman, I don't remember her name exactly, but she was a model and she suffered from anorexia nervosa, obviously, and she made these billboards to try to draw attention to the problem. And she was trying to get into recovery and she was trying to educate other people about it. And so she made these billboards, but even with her motivation and her desire to try to help other people, she did eventually die from anorexia nervosa. And so it's very sad. From what I hear, she was obviously somebody that was very giving to try to put herself out there, and somebody that's a model that really values her appearance to put these kind of photos of herself out there in the world. Obviously was very generous in trying to help other people, but she did die from the illness herself, so that's very unfortunate. All right, so looking at our quiz here, a child is started on Ritalin for ADHD. In educating the parents about the medication, the nurse will include which information? A, monitor height every 6 months. B, side effects can include palpitations and changes in blood pressure. C, monitor the weight monthly, and D, all of the above. If you want to take a moment to look at this, pause the recording. The answer is D, all of the above. All right, refeeding syndrome. So a patient that has been not eating or eating very little, if you try to refeed them in a very aggressive way, if you have too many calories at the start, you can actually cause sudden death. I remember when I first heard my patient on an eating disorder unit was at risk for refeeding syndrome. I had never heard of it before. It was probably presented in nursing school, but I didn't remember it. And so anyway, I looked it up and I saw it can result in sudden death. That's a pretty serious side effect. And so all of these things can happen. Seizures, what we see more often though are edema. You see peripheral edema. And it's just because the body is not used to those, that kind of calories. You see a lot of constipation, especially because the body's not used to processing food. And so it can cause the whole organ system to shut down. So generally, when we have a patient that says that they came in and they're eating anywhere from 300 to 500 calories, we don't start them higher than about 800 to 1200 calories a day. What we want to do is be able to make sure they can tolerate that amount of food before we start to ramp it up to help them restore their weight. Generally, if they are tolerating the food, we'll increase it within a couple of days. But it's very important to start off slow, start off 800 to 1200 calories a day. You'll also notice refeeding syndrome is something that you'll also see is a problem with patients that have been on TPN for a long time. If you're on a med-surg unit where somebody's in a coma or something like that and they're on TPN, you also have to be conservative with the amount of calories they start off with once they don't require TPN. All right, bulimia nervosa, you can see this is it's not very glamorous to have your face in a toilet. How bulimia affects your body, all the different things. I'm going to show you three of the symptoms to focus on in a few slides. But this gives you a general idea of how it affects the whole body. Now remember, with bulimia nervosa, the patient is not necessarily going to be underweight. In fact, they might even be a little overweight. So bulimia, this is the cycle of thought. One of the things in the field of eating disorders, they call patients with bulimia, they call them failed anorexic patients, that they would choose not to eat, most of them, but they give in and then they overeat and then they purge, and then all of these kind of feelings come around that. All right, so the three symptoms I'm going to tell you to look for. This is the first one. So dental erosion. One of the challenges is that in a patient, usually you'll see this kind of stands out, especially, let me go on to the next slide. I had a dental hygienist in my nursing class one time who told me this is what you see first and along those lines, frequently this is brought to the parent's attention by the child's dentist or by the young person's dentist. And so you can see the top enamel is worn away from the teeth, and you see the kind of pulpy stuff that's on the inside of the teeth. what's hard is to find in the very early stages is what's most valuable as a nurse to be able to identify. And those are harder to find images of on the internet, but generally what you'll see, it looks like the tooth is scraped. You can see most of our teeth are not perfectly white, but you can see some scrapes on the teeth, and that's the start of the enamel starting to be worn away. Usually by the time it's this extreme, that's already been brought to the attention of someone. All right, so our next objective sign of purging is Russell's sign, and that's a callus that's on the hand. It's usually on the first knuckle or the second knuckle, depending on how the person purges, and it's actually caused by the repeated motion of the hand kind of scraping against the teeth. It causes a callus to build up over time. Now, somebody that's developed the Russell sign has been purging numerous times a day, usually after every time they eat. Patients with bulimia don't always have Russell sign, of course, if they don't use their hand to purge. If they use some people will carry a toothbrush with them, and they'll use the toothbrush to go down their throat and make themselves purge. Also, patients that have purged a lot in their life, by purge I mean vomit, intentional vomit, they sometimes can know how to purge without having to put anything down their throat. So in Russell sign, it's not necessarily going to be there. The absence of Russell sign doesn't mean they don't have bulimia nervosa, but the presence of it, usually it does. Now, sometimes these can look like something else. I know one eating disorder patient I admitted, she had a little thing on her finger like that, and I asked her about it, and she said, no, it's because she has a new puppy. And so you want to always, don't assume that's what it's from. It could be something else, and it also could be the patient's going to lie to you if they don't want that to be known that they purge. All right, so the third objective sign of purging, by objective I mean physical, observable, is swollen salivary glands. The parotid and submandibular gland that you see in the slide here, those get swollen, and patients will feel like they have chipmunk cheeks, where they kind of look like a chipmunk, if you know what a chipmunk looks like. And so that's the informal name for it, is chipmunk cheeks. So for eating disorder treatment, they require, if they've been serious, once they're medically stabilized, the hypothermia, those kind of things are taken care of. They can come to a psychiatric unit like we have at Herrick, and they have a highly structured program. The meals are all monitored. The patient has to be on line of sight for an hour after meals and 30 minutes after snacks. There's a structured way that they're weighed in the morning, every other day, and after they, use the restroom in the morning. Staff checks them before their weight. Patients will do things like, we had a patient try to hide a book in her panties, and staff, they were tipped off by the fact that her butt looked like a book, perfect square. And so patients usually get away with these kind of things in their outpatient when they don't have those kind of controls. We have patients that kind of take the little weights from their father's fishing box and put those in their pockets to try to look like they're not as underweight as they are, things like that. All right, so some of the things we teach them: assertiveness, self-esteem, they have to give up their scale. You can't have a scale in the house. They'll weigh themselves every day and get really focused on those numbers. There's different ways of having these eating disorders. Sometimes, the most common one, of course, is focused on being very thin, But there's also an OCD component, obsessive compulsive type of component, with several patients that get really involved in the number on the scale. And so you can't have a scale in the house. And where you see here under groups, destroy skinny jeans shorts, I don't mean the brand like skinny jeans. What we mean is usually, and I would say probably most people have clothes in their closet that really don't fit, but you're hoping they will fit again someday. So you have like your clothes that usually were from when you were thinner, and you want to be able to wear those again. And for eating disorder patients, their clothes are really tiny, and so they'll have groups where they have them bring in their tiny little clothes from when they were really sick in their disorder, where they were severely underweight, and tear them up and destroy them with the support of the group. And so those can be some very emotional groups. All right, so now we're going to go into divorce, the effect of divorce on children. So there's two big longitudinal studies that had very different results. And what a longitudinal study is, it means it's followed the same people for a very large amount of time. The first one we're going to talk about is by Judith Wallerstein, and both of these studies they were both well done. The results of the first one, the Wallerstein study, she found that the results of divorce were lifelong. That kids were never the same. They let me go into that. That the whole trajectory of the person's life was altered by the divorce, and that they thought that the child's ability to have a relationship themselves was affected in the long run. And so this was, these came out in the 70s. And then the 70s, if you're not aware, there was what they called the sexual revolution. There was the birth control pill came out in the 60s. There was a large, most of the culture, most of the people were younger because of what's called the baby boom after World War II. There was a lot of babies born after World War II was over. And so there was a lot of young people. There was, some drugs being experimented with, a lot of social upheaval. Some of the social upheaval was it was for good things. It was, pushing for women's rights, pushing for civil rights for minorities, and a lot of it also, there was an unpopular war being fought in Vietnam, and there was a draft where that people from that age group were being drafted into the military to go fight in a war. And so I'm getting a little off track here, but it was kind of a bummer for it to come out, and because there was a feeling of being more sexually liberal in the culture. And so, yeah, so anyway, the idea that if you get a divorce, it screws your kids up forever, it wasn't popular. And then the results of the other longitudinal study by Hetherington, which was actually a little bit longer, 30 years versus 25 years, and a larger sample size. What they found was that most kids adjust to the divorce, that they function okay afterward. And so to summarize the literature is that kids can have a normal adjustment if the Hetherington, it found if the parents work together, the kids can be okay. And so it's not easy for the parents to work together. It means the children the parents have to put the children's needs above their own, and sometimes, as we all know, that doesn't always happen. A lot of effort has to be put to keep the kids out of the middle. Kids frequently feel like they have to take a side. But if you let that happen as a parent, that's when the kids get stressed. That's when the kids have problems. All right, so effects of the divorce on parents. Well, first of all, just life as a single parent, having to deal with the kid all by yourself. Usually there's an economic loss, especially if you're living by have to pay all the bills yourself versus having a partner. Conflicts with your ex-spouse, usually those feelings, they don't just go away when the relationship's over. You're still, you still have those feelings you can feel like you've been betrayed or abandoned. A lot of very painful feelings. When if your marriage fails, it's easy to feel like a failure yourself. Stress of having to date new people, that's very scary. Custody arrangements, frequently having to move. And then, if you have mutual friends, they usually feel like they need to choose between one of you. All right, so just a throwback quiz question here. A patient is admitted to the eating disorder unit. The nurse's priority intervention is to A, get the patient's weight and BMI, B, evaluate the EKG and metabolic panel, C, tell the patient about the unit structure, D, evaluate the patient for a history of abuse. So you can pause the recording right now if you want to take a minute to think about this and try to use your critical thinking skills. So pause it now if you want to do that. The answer to this question the correct answer is B, because when you're admitting the patient, what you want to see right away is, if the patient is in any kind of danger. And so checking out doing an EKG and a metabolic panel, you can see if their potassium is low and they're about to have a heart attack. If their EKG, if they have anything amiss like an arrhythmia, that can cause heart attack as well, or other problems. So you want to make sure they're medically stable. The patient's weight and BMI are, of course, very important, but not as important as making sure the patient is not going to die in the next hour. The other ones are important as well and would be part of your intake process, but not. First of all, you always have to make sure your patient is going to see the end of your shift. All right, so back to divorce. Immediate effects of divorce on children. The world is perceived as less reliable and less predictable. Increased anxiety, and then the sense of loss especially if one person has primary custody and the other person isn't around as much. Sometimes kids have guilt. They think that maybe if they had behaved better, that the divorce wouldn't have happened. And then, if they have to move, kids have strong connections to their where they are, especially if they live in a place where they know all the kids in the neighborhood and they have their friends and they have their little social circle. They lose that. All right. So the possible effects on children when they grow up is trouble rejecting unsuitable lovers because they might not want to. They might feel like they don't want to follow the same thing of giving up on a relationship. They might not want to have children because they realize that they feel like they were a burden to their parents growing up, trouble making commitments. And I left this on here, this slide is fear of being alone. It says especially women. Um, I just left it there for the conversation piece because I don't agree with that. I think women verbalize it more, but probably men have, and I'm a man, so that maybe I'm biased, but men tend to have less kind of superficial friendships, and sometimes they have, their spouse is really their best friend. Um, and so they might not have a lot of social support outside the relationship that has just ended. And so they can be very, feel very isolated. So what we can do is make sure they don't know that make sure kids don't think that they're responsible for the divorce. There's a lot of, books now that are made for kids of different ages that focus on divorce. And so those are educational and at their level. If they're an adolescent that can understand it, we can teach them the Elizabeth Kubler-Ross stages of grief, and then help them with whatever kind of peer support, different groups, you know, for people that are going through these issues. All right, so a nurse is doing a physical exam on a new patient. The nurse finds dental erosion, um, calluses on the patient's right knuckles, and swollen salivary, submandibular, and parotid glands. The nurse will suspect A, purging, B, severe caloric restriction, C, lanugo, or D, overexercising. So if you want to think about this, you can pause the recording right now. The answer here, hopefully you remember from a few minutes ago, the answer is A, purging. All right, so let's look at our objectives. So what are the characteristics of oppositional defiant disorder and conduct disorder? So remember, oppositional defiant disorder is usually an adolescent that's acting out, but they don't step on the rights of other people. Conduct disorder does step on the rights of other people, is considered much more serious and destructive, and that's somebody that could be a dangerous person. As you would probably guess, the person with conduct disorder would be the one that would engage in the bullying. All right, so risk factors for suicide in adolescents. The big ones that we worry about are, again, the bullying. If they're being bullied, if they have no future focus. That's why one of the things I said I'd like to ask, what do you want to be when you grow up? Another really big one is if they're gay or transgender and they feel like they won't be accepted if they reveal that to the people in their life. And so we want to make sure that they can feel comfortable coming out if they need to. All right, number 3, what was autism spectrum disorder without language or cognitive component formerly known as before the DSM-5? So that was Asperger's. All right, number 4, the 3 main subtypes of ADHD and what kind of behaviors might you observe with each? So the 3 main subtypes, the one more famous is the hyperactivity. The hyperactive subtype, there's the inattentive subtype, and combined. And so they're pretty self-descriptive for what kind of behaviors you would see. The hyperactive kid is not going to be able to sit in their seat. They're going to talk. They're also not going to be able to pay attention. But the inattentive one is the one that sometimes we miss, and because they don't draw our attention like somebody that's hyperactive, but they'll do really poorly on exams, and they have trouble following a lecture. And so that's a kid you want to make sure they're sitting somewhere where they're up front. They're not close to where they can easily look out a window or be distracted by other things in the classroom. And then the third type is combined, which is, they kind of have both of these. Number 5, what's important to teach parents when their child is on a psychostimulant medication for ADHD? And so the big ones are, remember, the stimulants can cause them to stop growing. So we want to get their height every 6 months and their weight every month. We also, since it's a stimulant, we want to make sure we teach the parents how to do a blood pressure and pulse and make sure their blood pressure and pulse are not elevated. What we worry about with Strattera is one of our medications that can increase suicidal feelings. So it doesn't have the problems with, it doesn't stunt your growth, and it doesn't affect your blood pressure, but it can cause someone to be suicidal. Number 6, what are some consequences of teen pregnancy? And, with that, it can cause the teen not to be able to finish their education. It can cause the teen to not get prenatal care just because they're kind of a kid themselves. They're not really a responsible adult. They tend to never kind of get over that, and never get over the setback from trying to get started in life, and have a hard time avoiding poverty later in life. So what are some medical complications of eating disorders? So medical complications, some of those would be hypothermia, where your body has no fat and so it can't keep in heat. We've seen extremes where on medical units, anorexia nervosa patients, they have to be put in heating blankets to keep some kind of heat in their body. Another big one is hypokalemia, and there's multiple different medical complications. I would say those are the 2 biggest ones we see. Number 8, what are some physical symptoms that you can see with patients with anorexia nervosa? Probably the most obvious one is cachexia, where they look like they're extremely thin. They look like almost like a concentration camp survivor, or somebody in a they're starving, and so severely underweight. Muscle wasting. Remember, you can see that sometimes, like especially in the shoulder, you can see the bone because there's no muscle covering it. And then another symptom of with anorexia nervosa, their BMI is going to be under 18. Number 9, the physical symptoms of bulimia, and what I'm really talking about here is the physical symptoms of vomiting, making yourself purge. And so we see dental erosion, we see Russell's sign, where they have the callus on their knuckles from making themselves vomit. And then swollen salivary glands in their cheeks and necks makes it look like they have the unofficial name for that is chipmunk cheeks. And then number 10, the 2 studies on divorce. The first one discussed, they were both longitudinal studies. The first one thought that kids were affected their whole life, and then the last one by Hetherington said that most kids adjust to the effects of divorce as long as the parents take effort to not have them stuck in the middle. All right, that is it for this And